السلام عليكم ورحمة الله وبركاته. محاضرتنا اليوم بعنوان Normal Radiographical Anatomy. Lecture 3. Radio opaque. Object that block radiation to pass through, such as metal, lead and bone, and appear white in X-ray film. Radiolucent. Object that permit the passage of radiation through, such as soft tissues, fluids and air, and appear black in X-ray film. Criteria of image quality. The full length of the tooth under examination and at least 2 mm of periapical bone must be visible. The evidence of pathological condition is present with surround normal tissues. Radiograph should have least amount of distortion or no distortion. Radiographs should have optimal density and contrast. Rising dot should be positioned at occlusal direction, face the source of radiation. As we see in this radiographical image, there is optimal density and contrast of the film, and there is no distortion. The position of rising dot not interfere with the area under examination, and full length of the root appear clearly with periapical area. The teeth are composed of pulp, radiolucent, therefore it appear black in color in X-ray. Enamel and dentine, which appear radio opaque and appear white in color. And cementum, that not visible because it has density like the density of dentine. Developing root shown by divergence apex around the dental papilla as seen here. There is incompletely formed root. Root canal open at the apices of adult incisor. The lamina dura appear as a thin radio-opaque layer of bone around teeth and around recent extraction socket. As we see here, this is the extraction socket and this is the teeth. Alveolar crest. The alveolar crest are seen as cortical border of the alveolar bone. Periodontal ligament. The periodontal ligament space is seen as a narrow radiolucency between the tooth root and the lamina dura. Cancellous bone. The trabecular pattern in the anterior maxilla is characterized by fine trabecular plate and multiple small trabecular spaces, while the trabecular pattern in the posterior mandible is quite variable, generally shown large marrow spaces and sparse trabeculation, especially inferiorly. The trabecular pattern in the anterior mandible is characterized by coarser trabecular plate and large marrow spaces than in the anterior maxilla. The maxilla. The important structure in the maxilla is the intermaxillary suture. Appear as curving radiolucency in the midline of the maxilla. The anterior nasal spine is seen as opaque V-shaped projection from the floor of the nasal aperture in the midline. Incisive foramen appear as ovoid radiolucency between the roots of the central incisors. The floor of the nasal aperture extended posteriorly, superimposed with maxillary sinus. The superior foraminae of nasopalatine canal appear just lateral to the nasal septum and posterior to the anteronasal spine. The lateral fossa is diffuse radiolucency in the region of the apex of lateral incisor. It is formed by depression in the maxilla at this location. The soft tissue outline of the nose superimposed on the anterior maxilla. The nasolacrimal canal are commonly seen as ovoid radiolucencies that opposing the position of upper 6 and upper 7 or between them. The inferior border of maxillary sinus appear as a thin radio-opaque line near the apices of maxillary premolar and molar. Zygomatic process of the maxilla protrude laterally from the maxillary wall. The maxillary tuberosity and hamular process extended downward from the medial pterygoid plate. The mandible. Mandibular symphysis in a newborn infant. Note the bilateral supernumerary primary incisor adjacent to it. Genial tubercle, which represent the attachment of genioglossus muscle, appear as a radio-opaque mass. Lingual foramen. On the periapical view, which is a sclerotic border in the symphysial region in the mandible. Mental ridge. On the anterior surface of the mandible, seen as a radio-opaque line. Mental fossa is a radiolucent depression in the anterior surface of the mandible between the alveolar ridge and the mental ridge. Mental foramen appear as an oval radiolucency near the apex of the second premolars. Radio-opaque superior and inferior cortical border on the periapical view represent the inferior dental canal or inferior alveolar canal. It appears radiolucent line with and surrounded by radio-opaque line superior, which represents superior and inferior border of the canal. Mylohyoid ridge running at the level of the molar apices and above the mandibular canal. It appears as a radio-opaque line. Submandibular gland fossa indicated by poorly defined radiolucency and the sparse trabecular bone below the mandibular molar. External oblique ridge seen as radio-opaque line near the alveolar crest in the mandibular third molar region. The inferior border of the mandible is seen as a dense, broad radio-opaque band. Restorative material. Amalgam restoration appear completely radio-opaque. A cast crown appearing completely radio-opaque, as this lower 6 which serve as abutment to the bridge. Stainless steel pen provide retention to the filling. It appear radio-opaque. Root canal treatment, which composed of gutta-percha, is a radio-opaque rubber-like material, appear radio-opaque in the canal and pulp chamber of the tooth. Base material, the cement, usually radio-opaque under the filling, but the opacity less than the amalgam filling. Composite restoration may be radiolucent, and we can differentiate between the cavity and the caries by well-demarcated outline of the cavity. Orthodontic appliance characterized by radio-opaque appearance. X-ray protection is highly recommended for individuals who may be exposed to X radiation. Include both patient and operator that exposed to X-ray that penetrate the body and absorbed by bone, organs, and tissues. Operator protection. Avoid hold the X-ray tube or film during exposure. Never stand at the path of primary beam. Barrier. Stand behind lead barrier about 2 mm and look to the patient to throw the leaded glass during exposure. This represents the lead apron for operator. Stand minimum 6 feet away from the X-ray beam behind the patient head at the angle ranged between 90 to 135 as shown in this picture. Patient protection. Necessary X-ray number, frequency, and type of radiograph should be adjusted. Filtration, high-speed film, low exposure time, minimum object film distance, and maximum film source distance. Adjust film exposure and film processing technique to avoid retake of X-ray. Use lead apron and thyroid collar. This picture shown the lead apron and the thyroid collar for the patient. Protection to the public. Warning, informative signal to indicate the hazardous radiation. Patient should sit away from X-ray room, full leaded of X-ray room. Patients are not allowed to wait in the corridor next to X-ray room. Thank you.